think TB, think TB, think TB. That's the first thing. And that diagnosis can be made on clinical parameters. And I very much liked James's idea to show the patient the different curves of the long unremitting cough, and that could be a really good, useful tool in practice. And good to hear from what James said also that WHO will be revising those WHO guidelines on paediatric TB, and that's also going to help us to discuss with our counterparts in the field, the Ministry of Health and the National TB programs, about the importance of diagnosing children principally with clinical means, and that most of them will not be bacteriological confirmed. We also heard about extrapulmonary TB and measures to reduce loss to follow-up, and of course contact tracing and the need to provide resources for that. So let's go straight to some of the questions. So first of all, to you, James. So in many MSF settings, we don't have X-ray. We have very little access to good quality laboratories. And what would be your advice to those MSF projects in those settings?
Well, I mean, I hope that in my talk and in things that everyone else is saying, we have stressed that you really don't need these extra tools to make a diagnosis. You need these extra tools to confirm a diagnosis, but to make a diagnosis, a good history, a robust clinical evaluation, and sometimes reappraisal after a short period of time, you should be able to make a decision on most children. So I really think it is possible to make diagnoses without these tools. But I think we do have to be honest, and I think we do have to acknowledge that these tests are imperfect, and even the clinical approach is imperfect, and it has imperfect sensitivity and specificity. And therefore, we need to decide what's worse. Is it worse to miss children who have TB and leave them off TB treatment? Or is it worse to sometimes make a diagnosis in a child who doesn't have TB in treatment? And I think that we as a community, if we want to reduce the number of children who are dying of TB, we need to become more comfortable stomaching treating some children who don't have TB. And I think that we need to increase the sensitivity of our approaches and reduce the specificity to some extent. So it'd be lovely if we had 100% sensitivity and specificity. It'd be lovely if we treated every child with TB and we never treated a child who didn't have TB with TB treatment. That's not going to happen anytime soon. So we need to think how comfortable we are there. And actually, the TB treatment is very safe. It's likely, as you mentioned, Kathy, that in the new WHO guidelines, the results of the SHINE trial, which have been made public, which have said that 4 months for non-severe TB is probably enough treatment. 4 months of therapy is not that different from preventive therapy, which you'd be giving these children much of the time anyway. So I think we need to be moving in that direction.
Great, thank you. That was really clear, and I think we're all on the same lines that, you know, TB treatment is usually very well tolerated by children, and yes, we may overtreat a little bit, but the main goal is to reduce this mortality by getting kids on treatment earlier. That's great, thank you. Just back also to you, James, there was a few questions about, well, if you do have access to microbiology, which sort of specimen would be best, and also what proportion of children do you think would have these pulmonary symptoms? Because we know especially smaller children often have very general symptoms, or just even something as little as lack of willingness to play or lack of appetite. Which proportion of children do you expect to have pulmonary symptoms, and which kind of samples would you expect would be the best to try to collect?
Okay, I mean, there's a lot in there. I mean, the second bit, which I'll answer first about I think that the majority of children have pulmonary TB. So there is a proportion who have extrapulmonary TB exclusively, such as meningitis or lymph node TB. But in terms of the symptoms, I agree, the youngest children, especially infants under 1, are often less specific. They don't have the cough, they don't necessarily have the kind of weight loss in the same way, they don't necessarily have the lethargy, and sometimes they don't even have fever. And so I think that, especially for children under 1, we need to have a really kind of a low index of suspicion for thinking about TB at least. And it might be, as you say, that it's just they're not quite right. The parents are concerned, the medical staff are concerned. They might be off their feeds. They may not be quite putting on weight as well as they might. They might not just be behaving as they have been previously. So I agree, it is quite challenging in the young children. And sometimes children living with HIV also have slightly less typical symptoms, even at an older age. In terms of the specimens, I don't think it actually matters very much. And people feel very strongly about this. And people generally do studies that prove their own biases on the whole. I think that if you, I think a gastric aspirate is a really good sample to take, but it needs to be taken ideally first thing in the morning. So that makes it quite a difficult ambulatory test to do. I think if you can place an NG tube the night before and leave it in overnight and get up at 5 a.m. before the child's woken up and started screaming and peristalsis has kicked in and the stomach contents go into the duodenum, and you can suck out the entire stomach contents, you will get great yields. But that's often not practical in a field setting. So if you get a child coming in at 10 and they've sort of been fasted, but they've been up 4 hours, anything that was in their stomach overnight may well have moved on. So I think in a kind of ambulatory field setting, often an induced sputum is a really good sample to get. A nasopharyngeal aspirate is not bad. I think inducing coughing is probably a good thing to do. It does require a bit of equipment with inhaler and then nebulizers and then suctioning, but it's I think that probably in an ambulatory way, doing that and getting a couple of good induced sputum is the best approach. But I think it doesn't matter. I think find a method that works for you in your context, work with your government partners and what is culturally the most acceptable, and get good at taking those samples and get a couple of them. And it may be the sequence is you see a kid, you get an induced sputum, you keep them overnight, you do a gastric aspirate, you do another induced sputum, you send them on their way. That might be in the right approach for some people. Others, you might bring them up in the morning, do an induced sputum, wait 3 or 4 hours, do another induced sputum, send them home. So I think it depends on your context, but just get good at one sample and use that well.
Excellent. Thank you very much for that very good advice. Great. We'll just see if we can get some input from Henry from Papua New Guinea, who gave us the presentation on the clinical cases of extrapulmonary TB. I know, Henry, you see a lot of extrapulmonary TB in your context, and I know you have some challenges with perhaps convincing people to treat based on clinical diagnosis, and also that we had some questions about TB meningitis and the treatment of that. Do you want to see if you can join us?
Sure, yes. With meningitis, it can be very difficult because there's just different causes of meningitis that can occur. It can be from viral, bacterial, or parasitic. If we have a child that comes in with a 2-day history of symptoms, that's more likely bacterial. The case example I gave, it was 10 days, so you're sort of borderline there. Practically what happens here, if a child doesn't improve in 2 to 3 days on bacterial treatment on ceftriaxone, we often just put them on TB treatment since it is a high burden setting and we have a lot of TB. In the case example I had, there was no history of actually any TB contacts. What I didn't write was that the child had rifampicin resistance detected on his gastric aspirate. So we sort of lucked out there and the child improved. So a lot of times if they don't improve on empiric bacterial therapy, we will put them on TB treatment because we don't have a lot to lose and we won't be able to treat for anything else if it is something else. Steroids, we try to make sure that it's at least 2 milligrams per kilogram. Sometimes people go a little bit low, but the official recommendation is between 2 to 4 mg per kg. What we should be thinking about more, I think, in our setting is the use of IV rifampicin, as well as potentially levofloxacin, which I'm aware they do in South Africa. However, sometimes instituting new treatment methods, you have to coordinate this with the Ministry of Health, and what they think and what you want to do doesn't always match up. And I'll stop there.
Thanks, Henry. That was really, really good input. Maybe Kemi, just carrying on from what Henry said about discussing with the partners about moving ahead on putting children on treatment. And I know that's a really important part of the job that MSF does in the field, is discussing with national TB programs and ministries of health to try to get everybody on the same page about trying to get kids on treatment earlier, even without bacterial confirmation. Do you have any experiences you could share with us?
Yes, thanks for the great presentations. This I've seen as a challenge in a lot of settings, especially with setting up new projects. But one of the things that it's a real barrier, but also a real chance for a great collaboration. And I've seen this in several of our settings. Specifically, I can name a few, like in Congo, in Sierra Leone, in Nigeria, and in South Sudan, where the Ministry of Health, first of all, just wanted to understand what we did in terms of how we diagnose TB. And when you end up looking at both of the methods of, especially the algorithm for clinical diagnosis, they're not much different. The main issue was that they wanted to have a correct process for registering these patients in their national TB program. And for some of them, it required that we do a specific questionnaire, like the Keith Edwards score in Congo, to fill that out for each of the patients so that they would have that as a supplementary thing to make the diagnosis. In South Sudan, they just wanted us to do an X-ray. It didn't matter what the X-ray looked like, but that it was done. And that, and as long as we did that and we said the child had TB, they were able to enroll the child in the national TB program. Sierra Leone required us to present each case to them, but the process is going to be different in each place. But most of the times, the barrier, unless they have a very sophisticated testing setup in terms of GeneXpert or other things, the barrier is in them just not understanding how we do our diagnosis. And us being able to work with them to see that most of it is pretty much similar with a few things, and you can negotiate with them on the things that are must-haves that will help us fill out and do that we can do for the patients each time, so that they will agree to enroll them in the national TB program. And most times that works.
Thanks, Kemi. I think it's always good to hear from others, and I'd encourage people in the lounge to discuss with other programs about how they succeeded in getting things done. And I think that maybe we could hear a bit more from Dr. Chara from Nigeria about the community aspects and how they really managed to reduce this loss to follow-up. I mean, we did hear from Martina that community interventions do take a lot of resources. Dr. Chara, would you like to give us some more ideas about what resources were required to reduce this loss to follow-up amongst the patients that you were seeing in your program?
Hello, everyone. So it was an interesting circumstance, because we work in an environment that is mostly, has insurgency. And so basically it's mostly a war zone area. And therefore, most of the patients we are dealing with are people who are coming from outside the city. And therefore, they do not have a source of livelihood. They're mostly in the IDP camps or staying with their families in the city. And their major challenge is mostly financial challenges. And we realized that most of them were not able to afford transportation from where they stay to our facility to get the drugs every 2 weeks. And part of our system was to ensure that we provide for them transportation money as well, so that every time they're about to come, we provide them the money for transportation. And we also try to put a call to them a day before their scheduled visit to the facility to ensure that they are aware of the problem and also that they come. Now, I understand this year, in addition to the transport money, there is also a provision for rationing, for food ration, because in many instances, they are unable to feed and they go somewhere else to look for food, and that prevents them from coming to the facility. So noticing that, we also added food rations to them. And in that process, they've been able to become more compliant and prevent themselves to the hospital. And this is why I think, even as at last year, we had a follow-up to about 5%, which is a very, very, very good improvement from previous years when we did no such thing. So I think for us, mostly, it's not that they do not like to come. It's more about the fact that they don't have the means. And so we provided the means in form of transportation and also in the form of food rations that would allow them to leave their job and come and get the drugs. And that way we've been able to work very well with them. Thank you.
Thank you. Thanks very much. I think it's even more important in these COVID pandemic days to try to get as much community stuff going as well, but it does take resources. Thanks very much. I think we haven't really had much said about a specific group, which was the adolescents. And I remarked that in James's presentation, he did show that during adolescence, TB goes up a lot. As he said, it was that nice primary school age that weren't affected as much as the younger ones and the adolescents. And I know that in MSF, we do a lot of specific things for adolescents with HIV. Maybe Laura, do you want to talk a little bit about something that we might be able to think about adolescents with TB in a similar way, perhaps?
Thank you, Kathy, and again, congratulations to everyone. So it's true that there is a lot that we can learn from the differentiated models of care that we have implemented across MSF. For example, setting up specific times for adolescents, or having specific peer groups or adherence clubs for adolescents. There are some projects also that have access to good internet, and they have specific WhatsApp groups. So there are plenty of things that we can do for TB that we are already doing for HIV. And I think that these are things that we could explore in our projects. Thanks.
Great, thanks a lot. So just coming back again to some of the diagnosis issues, because I think this session was really about what we could do to improve diagnosis. And I think we've made it very clear here that you just need your clinical training to think TB, and that is the minimum, and most kids can be diagnosed and put on treatment just with that. However, in MSF, we do often have the possibility to improve what's available. And certainly I think chest X-ray is something that is clearly a very useful tool, and probably much more than the microbiological tools. So X-ray is something not to forget about in MSF, and there's plenty of resources, telemedicine to help you read X-rays. And we have the diagnostic working group to help you set up X-rays and assess your needs. So don't forget about that. But we had a question from the field about CAD, which is computer assisted diagnosis of TB, which is using artificial intelligence or computer programs, if you like, to help you read X-rays. And we will be exploring that in MSF in some projects. In children, it's meant to be already okay to be used above 5 years old, according to WHO recommendations. There's a bit of lack of data for kids under 5 years old, because to train these algorithms, you need 10,000 X-rays of children. So I think at the moment, the computer-assisted diagnosis, we're not there for the younger children, but certainly for the over 5-year-olds. But X-ray with telemedicine to be used to help you read them is certainly something we can implement in MSF. So there was also another tool which is called POCUS, and as was mentioned, there is a stand that you can go and look at. But maybe Laura, you can talk to us a little bit about your experience of POCUS. Just tell us first what it is and what you think its role might be in TB.
Thank you, Kathy, again. So POCUS point of care ultrasound has not yet been validated for diagnosis of TB in children, but there is a methodology that is very well studied in adults with HIV that is called FASH. And that's the reason why we are performing this operational research, first of all in Guinea-Bissau, and then now in Malakal. You all heard the presentation. And what we are trying to see is whether this FASH methodology is also useful for diagnosis of TB in children. We don't have enough data yet to affirm that it's really useful, so we need to be cautious. I for sure believe that it will have a role, but for now we still need to wait for the study to be completed. If it's your case that in your project you can perform FASH, you have been trained to, you can always post images in telemedicine and seek for expert advice. But in any case, again, coming back to the main message here, the main diagnosis is clinical. So whether you have POCUS or not, if you believe your patient has TB, please go ahead and treat. That's it. Thank you.
Thanks very much, Laura. Okay, so just coming back again now to treatment and prevention. So we talked about, Martina gave us a fantastic overview of the CAP-TB study, which is going on in many countries, but I think we can take quite a lot of lessons learned from that. And, you know, thinking TB, so in your OPDs and IPDs is going to find you a lot of TB cases, but also following up on contacts, and that can be following up of children, siblings, or adults who are parents of children with TB, or children who are related to somebody in the household with TB. And I think, Martina, maybe you can talk to us a little bit more about using this rifampicin isoniazid 3 months treatment. You said it was very well accepted because it is the part of actually a TB treatment. It can also be used for prevention, and so it was available and cheap and well tolerated. You also said that there was a lot of resources needed to be invested in the setup of the program. But if you had to give us any sort of advice for an MSF setting, what would be your take-home messages, do you think, knowing that you know MSF well?
So I think basically the TPT part really, and uptake of TPT, I really think it would be something that would be great MSF to focus on, because it's, especially when it comes to the children under 5, you know, it's a little bit, they go hand in hand. Since it is so difficult to diagnose TB, you really want to put a lot of emphasis on preventing that they get TB, right? Because we know that when, you know, still, even if you focus only on the clinical diagnosis, or you really try to build capacity to clinically diagnose TB, still it will be challenging. So you better try to prevent it. And I think it's just a matter, my experience through CAP-TB has been that unfortunately has not been prioritized enough. It's not been under the spotlight enough, right? In the last few, is only now that is kind of raising a little bit of attention. So, and for us, it was quite surprising also to see how many children you managed to find with TB through this contact investigation. So it really looks like it's an important gateway for both. One, getting children on prevention, and on the other side, to really find early the cases that otherwise you will miss for some time, and when they will come to the facility might have a much more serious disease. And they, you know, it will be maybe also increasing the mortality, et cetera, et cetera. So I think in a resource as MSF, I would say that my perspective comes from a project that has been implemented in close collaboration with the national programs, and where we really had to focus a lot on sustainability, and yet it was feasible. So I would think it's even more feasible, knowing, you know, MSF a little bit. It was even more feasible in MSF settings. It just needs to be prioritized, and the link with the community health workers, you know, it's just about building a good, let's say, plan for community health workers that are needed to help reaching out the communities, and good linkage with the TB focal person or nurse that sits at the TB clinic, because at the end, the big coordination point for contact investigation activities, in our experience, is the TB unit. Is from there that, you know, you get the adults, you get the line listing of your contacts, and you start from there. So
great. Thank you so much, Martina. That was really clear. Thank you. We're coming to the end of this panel discussion, but I just wanted to come back to this idea of believing in your clinical skills. If you think a child has got TB based on a clinical diagnosis, the child has got TB, and you start treatment. You're not testing the treatment. This is not a trial of treatment. We don't do trials of anti-TB treatment. You've made a diagnosis. It's not confirmed microbiologically, but you've confirmed it yourself. You believe it. It's a diagnosis of TB. Don't worry that you might overtreat a few kids. Kids support the treatment well. There's no risk of drug-resistant TB because we're using fixed dose combinations. So a few kids overtreated, this is not going to be any problem for drug resistance. It's not going to be any problem for that kid. But you will save lots of lives. If you treat TB early, you will save lots of lives. You will reduce that mortality. You don't want to see those kids coming when it's too late or never coming. As James has showed us clearly, there's so many kids who are never diagnosed and never treated. So have confidence in yourselves. Think TB, diagnose clinically. You can do it, you can do it. And I'll just say one last thing. There was quite a few quite technical questions about lab stuff. There's an excellent module, WHO guidelines, module 3, which has all the diagnostic information you'd like to know about. What is the yield from different specimens on expert? What sort of tests to do in which situations? And the operational handbook is really good. So I'll see if I can put it in the resources, and most of your questions will be answered there. But also we'll all be in the lounge afterwards, so we'll look forward to seeing you there. Okay, thanks very much. I hand over back to you, Alexandra.